Good morning. My name's James Stanger, and this video I'd like to address the issue of electronic witnessing, both a product review and also the information involved in the electronic witnessing system. So let's just start off. This is a client, an embryologist, and a CEO's worst nightmare. Savannah IVF mix-up case heads to mediation. Where a lady had an embryo with donor sperm. She ended up with a baby that wasn't hers. And this one was Monash, where a same-sex couple had the wrong embryos transferred, but they are a nightmare for everybody. No one wins in these situations. One interesting thing that one just came recently, woman gives birth to a baby that isn't hers, sues Florida IVF. But what's interesting is when you read the article, there's one interesting twist is the scenarios, whereas the child is not genetically related to the parents, is who is their embryos, right? How can a clinic identify or trace events that occurred in the laboratory 12 months ago? And if these embryos aren't hers, what's happened to her embryos? How do you trace it? And the electronic witnessing system is part of that process. By way of introduction, clinics are getting busier and busier. Staff are under pressure to manage embryos, and embryos pass through several hands on the way to transfer. And I think there is largely a large disconnect between embryologists and doctors and clients. Eggs, sperm, and embryos can be stored for a long time. The system can change, staff can change, and tags become blurred, particularly if they're old. Samples are moved multiple times with multiple thaws and audits. Clients change status or historical status change. I know one case where the woman had 3 husbands over the course of 5 years, or 3 partners. And they're also more complex, particularly with same-sex couples and rapid transfers. The errors may not become apparent for some time, but society is very quick to blame and the costs can be enormous. I have quite inappropriately made comments that the paternity issues relate in the society about 2 to 5% of all pregnancies. Of course, that's totally irrelevant to the conversation, but except to say that in IVF, the errors are very, very low. When you consider there's probably 30 million babies born so far, and the error rate's probably in the order, let's say 1 in a million. It's really, really low. But at the end of the day, regardless, it should be 0, and it's all to do with trust. So quickly, just look at the guidelines, and there are guidelines. Then we'll look at the products on the market, then some recent reviews of publications on electronic witnessing, and then my views at the end. So the ESHRA Guidelines on Good Practice in IVF, published report on human reduction 2016. Section number 4, identification of patients and traceability of their reproductive cares. And this is what it says. This is what all clinics must abide by if they want their accreditation. Identification of patients and traceability of their reproductive cells are crucial aspects of ART treatment. Each laboratory must have an effective and accurate system to uniquely identify, trace, and locate reproductive cells during each procedural step. The rules concerning the correct identification, this is all pretty boring stuff. I know you can read it, but I'll read it out to you anyway because I want to. Concern the correct identification and processing of reproductive cells must be established in the laboratory by a system of codes and checked. And these include direct verification of patient identity and correspondence with their assigned unique codes is required at every critical step. Patients should be directly asked to give their identifying information or at least full name and date of birth before procedure or artificial insemination or embryo transfer. But I'd like to make a comment here. It's not only is the entry to the transfer room, but also with the embryologist who is loading the catheter. So I think there needs to be a very strong connect between the embryologist and the client and the doctor at the transfer room. In many cases, I think it's just passing a catheter through the wall, which really is unsatisfactory. All devices containing biological material must be clearly and permanently labelled with a unique patient ID and code of treatment, but you have to be able to read the name. You have to be able to read the name. You can't just have numbers and codes or barcodes. Biological material from different patients must not be processed in the same area at the same time, and I think our EWS systems really force that. Incubators and cryostorage systems should be organised to ensure easy access and identification of biological materials therein. During critical steps such as the identification of cells and tissues, each time biological material is moved from one container to another, and at final destination, either transfer or cryo containers, They must be able to do the checks by a second person or by an electronic witnessing system. And moving canes and straws in and out of cryo systems is becoming absolutely quite horrendous and quite dangerous. And everyone's quite terrified of going in and out of these huge cryo storage. And I think this is one of the reasons that we have some concerns. Products and materials used with biological material must be traceable. The date and time of each manipulation and the identity of all operators and witnesses must be documented throughout the treatment. These records should be kept for a specific period of time according to European and national standards. And I think I make the interesting point here that gametes and embryos from non-partner donations may require special codings for those countries where are regulated according to the European customs. So double checking is the standard system which we've used for the last 50 years. It involves two sets of eyes on the identification of any sample with the patient file and a sign to say that the check has been made as it correct. But I'd like to make an aside here. If you're a client, one of the first things you should ask during your information workup is, how does your clinic manage your embryos? How does the electronic system work? And you should know what the clinic does with your embryos and how you can be satisfied it's yours. You should ask. Types of witnessing, manual, electronic. The critical things I like to make here is, because of time restraints, the manual system is limited to only very few specific embryo handling steps. All others are done by a single embryo signing off on a spot on the worksheet. But these critical ones require two staff to sign off at each step, and often the signatures can be unclear. If it's just a notate like JS, you often don't know who that is, particularly years later. Electronic systems can be extended to many steps involving gamete and embryo handling and a lot more. That's one of the real advantages. You can see here all the different steps that have been made. However, the database needs to be current. If there's a change in system, you can end with old data. You can end up with huge data volumes that need to be backed up and managed securely. And they may not necessarily be manually accessible to all staff. But one advantage is there are alarms and alerts to tell you something's wrong. And there is a cost to it. I mean, you might argue that it's less than the legal cost, but the cost of now documenting this is now going to be a serious part of the cost of IVF. And just a worksheet, which you'll see a bit later. But if they look at all the little interactions where you may want to have a label that's being managed, I've highlighted a couple of things which I think would require double embryo handling. So there's a lot of iterations occurring that require just a single signature of the operator, but there's only a couple that are critical that require double witnessing. So there are 4 systems on the market. If there's one I missed, then please go to the comments and tell everyone else what other systems are which are available. And if I missed you, I apologize, but there's 4. If I know this is the first initial one, the RI witness system, which I think is probably the better one. They use, like everyone else, a radio frequency ID. The ID works as a tablet computer connected to the server, integrate the patient's database. And this is one of the problems, that you need to integrate it into a database in some way to make it work. So they use self-adhesive tags attached to plasticware. It's a system's automatic, so it doesn't require steps by embryologists to identify the samples. It ultimately tracks, monitoring, and records access to all working areas, and the witness frees up time in energy and expertise. This secures fills everyone with total confidence. There's a second one made from an Australian group, Geneo Biomedics, the Gidget system, which, as I understand it, uses a handheld system to identify the barcodes, ROD codes. There's a third one by ESCO Medical called Mirror, evidence-based RFID system, which I understand is actually very good. And the fourth one, IMT Matcher, which I understand has just been sold to an American group, which told you it's worth. But once again, these all use a barcode electronic system, which can work both in the freezers and in the lab. Incidentally, I've tried to contact IMT Matcher several times by email, and they have not replied, whatever that means. So let's just look at some of the publications that are involved in looking at how these things worked. So when I started looking, these are the first 2 that I started with, that the search came up with. But then I quickly realized there were a lot more. And I'll quickly go through all of these, just quickly to highlight the critical things that they've brought forward, which is actually quite a good thing. I've quite enjoyed it. So the first one was 10 years ago. from Italian group looking at a survey of what people thought about an electronic manuscript system. The object of this study was to evaluate patient concerns about IVF errors and electronic witness systems. The conclusion, EWS, by sensibly reducing the risk of sample mix-up in IVF cycle, has been proved to be a trusted strategy for patients' perspective. 90% of patients express significant concerns about sample mix-up, and the EWS reduced his concern in 92% of people, and 97% they were really happy that there was now electronic traceability, and 97% of patients felt highly comfortable with a centre equipped with EWS. It's a bit of public relations. Interesting, female patients had a significantly higher appreciation of the EWS compared to their males, but they made a comment that there was a mix-up occurred just recently in an Italian hospital during the study, and that made everyone really happy with the EWS. The point I got from this article was that if your clinic has an electronic witnessing system, that's an important issue for clients, and you should tell them, and they should ask. So I think this is something that you should promote your business with. There's another one that from the States, looking at double. I'll get back to this one. Basically, it says the object was to examine it by head-to-head comparison with manual and double witnessing systems on electronic systems, and they concluded that the electronic witnessing can significantly reduce the overall time required for double witnessing 3 to 5-fold. For the first time, this data represents a fair comparison between manual, double witnessing and electronic systems as they account for the second witness interruption time. And they make the comment that an EWS may help improve laboratory efficiency and workflow by minimizing interruptions, which have long been underestimated in today's complex IVF laboratory practice. There's a system also report just from an Indian group where basically they indicate that EWS is one of the recent advances in the field of IVF that use radio frequency devices to monitor all critical work carried out at each stage. The main objective of this study was validation and integration of the EWS in terms of efficacy on lab performance and on the quality of the embryos. And they concluded that their preliminary studies suggest that the EWS does not affect the gametes, embryos, and pregnancy rate. However, larger trial, there was no way I have to say that. And this is what I love. They produced an elaborate workflow chart just illustrating all the iterations that may occur in the movement of a patient and their file from collection right through to completion of the cycle. And basically, they noted that of 751 tags that were involved in 77 patient-assigned barcodes for all the analysed cycles during validation of the EWS, a total of 2.4% red flags were highlighted from the EWS system from pre-allocated tags within the frequency range of the recorder, but basically they're saying that all the embryology appeared to be unaffected by the fact that they were being monitored by EWS. But they had this interesting chart, which I thought was really groovy. It just goes to show how many different steps are involved in the life of an IVF cycle and how many iterations occur where any one of these have the potential for a mix-up. And it just goes to show you that the potential to create an error is huge inside any one IVF system. And people need to be aware that each of these steps does need to be validated. If we go back to looking at this article by Jason Swain, etc., this study used the Gidget system, which I did approach for sponsorship, but they just decided not to. They concluded the EWS may improve laboratory efficiency by significantly decreasing the time required for witnessing procedures and by minimizing interruption. It was well perceived by the embryologists and lab managers and enhanced their confidence and peace of mind with regard to witnessing compliance and safety and accuracy. But this figure I thought was really interesting. This gives you an idea, this is in seconds, of how much time the EWS system takes compared to manually checking and then the checking of the double witness. And it just goes to show that that second person, that double witnessing, involves a lot of time and effort and is quite disruptive. Once again, like this, I've shown you this before, this is just the workflow that they've identified where in fact each iteration can be validated. And just quickly, there was an article in 2003 in Reproductive Science talking about automation, but they made the point that if we're going to move forward to a more automated system for IVF, which we'll probably need to, considering how complex it is, radio frequency tracking devices will be essential to the further integration of automation, including witnessing. There was a report from Belgium Group in 2003 looking at reviewing after 10 years of using a system. And they basically said, what have we learned after 10 years of electronic witnessing? When applied correctly, an electronic witnessing system can replace manual witnessing in the medical assisted reproductive lab to prevent sample mix-up. Electronic witness systems have been implemented to improve the correct identification, processing, and traceability of biological materials. When non-matching samples are simultaneously present in a single workstation, a mismatch event is generated to prevent sample mix-ups. And there are wider implications of the finding. This is a really nice part of human reproduction articles, the wider implications. Electronic witnessing is considered to be the ultimate tool to safeguard correct identification of gametes and embryos. But this is only possible when used correctly. In proper training and attention to staff is required, but it may also introduce new risks such as blind witnessing of samples by the operator. That means that if the operator puts the sample on, if it doesn't beep, it's the correct sample. They reviewed 109,000 cycles, 53 IVF, 36 FETs, and 20,000 IUIs. They used 724,000 tags in 849 witnessing points. But here's what I thought was really interesting. This is where they started to report the total mismatch, which was 2.5% per witnessing point, or 1.9% per cycle. So each cycle had, in every 100 cycles, there was 2 mismatch events that occurred somewhere in that system, which doesn't sound much, but when you consider the number going, that's quite a lot. That could be 1 a week, maybe. In total, 144 critical mismatches occurred at different procedures. The yearly mean critical mismatch was 0.007% per witnessing point and 0.129 per cycle. So it's about 1 in 1,000, 1 in 500 cycles will have an error. 1 in 500 cycles. That's a lot. Sperm preparation and IVF ICSI were the procedures most prone to critical mismatch and administrator assigns. There's another study from West Australian group. They asked what were the risk factors for mismatches involving or not involving biological material and critical mismatches, CMMs, involving biological material in IVF lab equipped with an EWS. A total of 73,000 witnessing points were extracted from data from 11,000 conceded treatment cycles. But that tells me that there are only 7 witnessing points per cycle. Overall, there were 138 mismatches and 16 critical mismatches were identified during the study. There were significant differences detected both mismatch and critical between different time periods of the day. And their conclusion were mismatches are associated with specific laboratory procedures and with individual operators, while critical mismatches were associated with the time after 4 o'clock and with oocyte denuding. So don't need to, I'm basically repeating that. Now here's something to get your head around. You need to go back and read the paper. It's a free article. But this is basically what they say. Neither mismatches nor critical matches were associated with a specific weekday or weekend day, so it's not read to the day of the week. Both mismatches and critical mismatches differed significantly between 8 laboratory processes. The mismatch rate was highest during embryo transfer, and the critical mismatch was highest during oocyte denuding. Furthermore, the mismatch, so this mismatch rate here during embryo transfer just tells you that there was a dish moved into the work area that wasn't the one allocated to the patient you're dealing with. There could be lots of different reasons for that. And so the mismatch may not indicate potential error. It's just that one of the rules are you don't have two different samples in the work area at the same time. But if this mismatches with the file, then that will be recorded as an error. Furthermore, I noted the mismatch rate differs significantly between the 20 operators, whereas the critical mismatch rate was not different between operators. And I just need to go back. Basically, logistic regression found 6 laboratory processes in order from highest to lower were oocyte denuding, embryo transfer, cryopreservation, sperm preparation, oocyte collection, and insemination, and 4 individual operators. So I just need to go back and look at this. So the critical step in their lab, and it may be different between different labs, of course, was oocyte denuding was where they had the wrong error. That is, they went to go and denude some oocyte to do ICSI, but they had the wrong file set up. And so this is where you have a potential mismatch with the oocyte, not the sperm. And it was highly significant. So in other words, clinics need to take note of this, that the process where you're about to collect get the eggs out of the incubator to denude them, that is a critical risk step, and clinics should be aware of that. The transfer one was also fairly worrying. The cryopreservation, sperm preparation, oocyte collection, insemination, they're all highly significant. So in other words, these really are the critical steps in IVF. And it was, even though the rates were fairly low, it was still a worry. But what's more interesting was that there was differences between 4 different operators. So some staff members were making more errors than others. And that would be part of one's annual assessment and part of one's KPI. So just reiterating this paper, univariate regression analysis in time after 4 o'clock and oocyte denuding were the only risk factors associated with critical mismatches. And that tells you kind of that at the end of the day, you're about to do the ICSI, you have several ICSIs to do, and most of the staff have gone home. You're left there by yourself, maybe with one other staff member, and you have to denude these oocytes to get the ICSI performed before you leave. And that tells me that that's end of day work, and we need to be very careful of that. So my comment here is these articles do demonstrate that data mismatches do occur, but they occur at a very low rate. It does demonstrate that despite what the news headlines imply, IVF by and large is relatively safe and secure, and the electronic wisdom system just makes it a bit safer. But one assumes these mismatches that occurred were identified by the EWS occur in a manual system, but maybe even at a higher rate because there are no alarms. And just lastly, there was a study just getting back to manual systems, published September last year from an Italian group, where they surveyed what the embryologists thought about double witnessing. So this was survey of 263 respondents. Only half of people who sent the survey out responded. Most participants had over 5 years experience and worked in medium to high volume centres. The key findings revealed that 90% preferred verbal confirmation as reading aloud the name and the details of the step is the most effective for witnessing strategy. And 3/4 of the people emphasised the necessity to referring to documentation or critical stage. The process that is, you don't say, is this straw belong to Mrs. Jones? You have the file out, you have the straw, and the second witness, the double witness, has to look at the file and the name, and then sign it, basically looking at both of them. And just lastly, they do recognise there's chaotic environments, lack of attention during witnessing, and staff shortages were identified as significant sources of error. And I think this is a common thread. And clinics that run their stuff too chaotically are asking for trouble and to pay the price in the legal system. But importantly, 83% agreed that witnesses must be a health professional trained in the procedure. You can't just grab a nurse. You actually have to have another embryologist. And this is one of the things about manual systems is you then have to wait for that second person to become available to check. So there's a lot of waiting going on. Embryos being out of incubators while they're being confirmed, and a whole lot of steps are being delayed until that double witness occurs. So in conclusion, effective human witnessing in ART laboratories involves structured protocols emphasising verbal confirmation, standardised documentation, and monitoring of high-risk phases. Witnessing tasks require trained healthcare professionals, and per procedure shift organisation enhances attentiveness and reduces fatigue. Okay. And just lastly, I listened to a podcast from Disc Inside Reproductive Health, which some of their things are quite good, where the CEO for Pinnacle Fertility in the States was talking about a lot of different things. But during this 51-minute podcast, she did mention the fact that they had built over their 4 clinics an in-house system for an electronic witnessing. And she was basically saying that the cost was millions of dollars a year to buy one of these professional EWS systems. And if you're a clinic that's running 3 or 4 different laboratories, it may be better to write your own EWS system in-house so that it fits in perfectly with your own software. So it just recognised that sometimes rather than just buy these systems out of hand, if you have an in-house data developing system and your own database system, it may be of interest to write a specific EWS system for your database for all the reporting as well. So it's all well and good to demand an EWS system, but there is a significant cost to their use. In-house systems do need to be validated. Okay, just to finish up, just a couple of thoughts. And unfortunately, I've got a few thoughts on this. From everyone's point of view, manual or electronic systems are a quality activity that must be applied to every step that involves human tissue. Manual systems have been the standard process since IVF started more than 50 years ago, where most steps required signature to identify who did that step, but only few are required to be double witnessed. Manual systems need clear documentation and auditing to follow the rules are followed. So part of one's auditing system for good quality management is actually should audit all the documentation has been signed off by people that you can read. It may become part of a critical KPI reporting to senior management because they will ultimately pay the price. In fact, they should be demanding it. It may be logical, please check means 2 pairs of experienced eyes, but flawed when not followed and the labelling is unclear or aged or faded. And many samples that you pull out of the freezer haven't stood the test of 10 years in cryo storage. As some studies show, it can be disruptive to the procedural flow, stopping to get a second witness. It may impact on quality if waiting or exposure times are excessive. It's often difficult to quantify an audit, and also signatures may be difficult to discern, especially if staff are left. You do need a signature list, and that can be validated at all times. But having said that, even though there have been some cases, there have been very few errors in the last 50 years. If you look at the number of legal cases, there probably would be less than 20 or so that I'm aware of. But it's probably even a lot less than that. I can only think of about half a dozen, but they don't always get in the news. So my thoughts on electronic witnessing systems, they're a far more attractive option to manual systems. They force a rigorous quality system in the lab, only one biological sample in the workspace at any one time. Records correct and incorrect iterations allow auditing and reporting, both staff members and for senior management. Allow staff to work independently with confidence, especially if alerts and warnings stop potential errors from happening. It may also, though, lead to the concept of blind witnessing, whereby you put the sample on. If it doesn't beep at you, you think, oh, that's okay. It's also a less stringent approach to handling and checking whether the system will actually alarm if incorrect. That's what I just said. There's some other ones, limits the activities to specific areas. So you can only do your work in the area where you actually have a tag system in place. That there is a cost. It's a huge cost to doing this for the tags, etc. But it may be cheaper than legal and reputational costs. But documentation made to be separate to the workstation notations. So it means your workplace has fewer signatures if you're relying on the EWS. And therefore, when you look at your worksheets, you can't actually see who did that. So electronic-based systems may have and should have limited access. You don't want the system to be accessed by anyone, so that only certain staff members have access to it. But however, the real problem will be, and this will happen because it's happening all the time, changing from one system to another in the future, and with it, external material an issue. And I think this is one of the real problems. If you don't embed in your documentation system all the auditing checks that are going on, no doubt some system will become too expensive and other ones will become cheaper, and clinics will want to go to a cheaper system But when you change from one system to another, you then have the problem of maintaining all those past data, because it'll come back to haunt you in 10 years' time. I've been involved in a case where there was a disputed transfer, where one embryo was transferred and twins were delivered male and female. But using a manual system, I was able to clearly demonstrate that for each step in the creation, freezing, thawing, and transfer of the embryo, there was a clear double verification by 2 staff members. As it is, turned out mixing intercourse and FETs was a risky treatment, but the real value of each and every witness step must be it's visible to our requesting client and clear and transparent. It gives you proof of internal confidence that the system is virtually foolproof. And you must be able to demonstrate that it is foolproof to clients and to the legal system and to your bosses. So I support an EWS system because clinics are now so busy and multitasking, the staff need to be able to work quietly and efficiently and accurately. My concerns include that they may induce a complacency in checking the ID of each tube and dishes and rely on the alert system to check your processes. I note that publication records low but present errors with incorrect dishes and tubes in the workspace that may or may not contain biological material. I also worry that a new patient management system may need a new electronic system that makes auto tag problematic. I've seen whole patient management system files rendered useless by the introduction of a new personnel. In one laboratory and one hospital I worked at, 10 years of electronic systems were lost overnight when the new system replaced the old one. And the old system became redundant. They couldn't even access it. It was a disaster. There is also an issue with external material being transferred in a system that may not be able to process it correctly. And increasingly complicated treatments such as ROPA, where different partners' embryos are swapped to transfer. And trying to manage that inside a patient management system, it can be really complicated. I think for each cycle, the data from an EWS should be printed and attached to the medical record. That is, once the system has been finished and the outcome has been known, you should print a copy of the electronic system that goes in the patient file and sits in the patient file forever. Even if the system fails, you've always got a copy of it. This allows, on the confirmation that all is correct, and to ensure the record is always available in case of system error. Lastly, a transfer, there does need to be a manual double check system in place. We should not get away from the fact that at that transfer, you shouldn't be relying on the electronic system. You should still have a manual double check system in place. And I'm harping on this, I know this, but I also think the medical staff performing the transfer need to be part of this process. I've been doing IVF since 1982, and lots of doctors walk in and just expect the embryos being transferred belong to the patient. But I've often been critical that, in fact, the doctor should make sure it's their responsibility, they're the doctor, that in fact the embryos belong to the patient. They should at least check the file or the cryopreservation tool or the embryo culture dish. Lastly, the impact of the client is real, but without being callous, they can't be compensated. I know that's a terrible thing, but at least there is a compensation. But no one thinks of the scientist who makes an error. They don't do it deliberately. They wouldn't do a deliberate error. It's one that they don't even know they've done. But if it's ever worked, if they ever are made aware of it, it's a big burden for them to wear. Financially, any error will cost the jobs of many who are unrelated to the actual events. Look at Monash of IVF that have claimed many of their senior management. So it's something that we do need to take a lot of care of. My last thoughts is clients place enormous trust in the integrity of a clinic to transfer the correct embryos. Even though there are the occasional reported errors, there are few and far between, given testimony to the skills and processes that have always existed in IVF. Very few errors should give clients confidence in the systems. Given that just one tiny error, a misreading of a 5 for an 8 or a Smith for a Smith may occur in the blink of an eye, and years before any error may be detected, can have such far-reaching effects, means that both electronic systems and manual systems need to be used for each and every step of every IVF journey. And that, I'm exhausted, is the end of this talk. Just wanted to have a disclaimer. My name's James Stanger. I'm a PhD. I'm an embryologist with more than 50 years experience. The video is part of my Third Age YouTube channel and my attempts to bridge the gap between information you may need for your fertility treatment and the most recent publication to your clinic. I'm not a medical person, and this information is not medical advice, but it may help you in knowing what questions to ask about your treatment with your doctor and maybe help in understanding you receive. I hope it helps. I'd like to thank you. I know that IVF is a personal journey that involves the action of many techniques, people, and events, and it helps to understand all aspects of that journey. I hope this information may be of value. If you like the information provided, please tell other IVF clients about the service and please subscribe. And that, my friend, is the end of this video. Thank you and goodbye.